Question 1. A full-term neonate is delivered with an UPGAR score of 3 at 1 minute and 6 at 5 minutes. The baby is breathing but with a weak cry and slightly cyanotic. The healthcare team initiates positive pressure ventilation (PPV). What is the most appropriate next step after 30 seconds of PPV with no improvement in the baby's condition? A. Increase the oxygen concentration and continue PPV. B. Administer intravenous epinephrine and continue PPV. C. Reassess the airway, consider intubation, and increase the pressure during PPV. D. Start chest compressions immediately. Answer. C. Reassess the airway, consider intubation, and increase the pressure during PPV. Explanation. In a neonate with persistent cyanosis and no improvement after initial PPV, the next step is to reassess the airway to ensure it is adequately cleared and consider intubation if there is inadequate ventilation with bag mask. It is also essential to increase the pressure during PPV to deliver sufficient tidal volume. This step is critical. Moving to more advanced measures like medications or chest compressions. The use of epinephrine is reserved for situations where the heart rate remains below 60 bpm despite effective chest compressions, and chest compressions should only be started once the heart rate is under 60 bpm, even after adequate ventilation. Question 2. Mr. Smith is a neonatal nurse who is performing resuscitation on a premature infant with a birth weight of 900 grams. The infant is unresponsive and has absent respirations. Mr. Smith begins positive pressure ventilation (PPV). After a few minutes, the infant's heart rate remains below 60 bpm despite effective ventilation. What should Mr. Smith do next according to the Neonatal Resuscitation Program (NRP) guidelines? A. Continue PPV, reassess the infant's temperature and provide warmth. B. Administer epinephrine via the umbilical venous catheter of C. Start chest compressions immediately with ratio of 3:1 compressions to breaths. D. Increase the oxygen concentration to 100% and continue PP. Answer. C. Start chest compressions immediately with a ratio of 3:1 compressions to breaths. Explanation. For a neonate with a heart rate below 60 bpm despite adequate PPE, NRP guidelines recommend starting chest compressions immediately with a 3:1 ratio of compressions to breaths. This ratio is designed to maintain adequate circulation and oxygenation until the heart rate improves. The priority is to restore cardiac function through chest compressions while simultaneously continuing to provide effective ventilation. Epinephrine is administered only if the heart rate remains below 60 bpm despite chest compressions, not before. Increasing oxygen to 100% is useful but should not replace the need for chest compressions when the heart rate is critically low. Question 3. A newborn infant is delivered with a thick meconium-stained amniotic fluid and the infant is not crying. The neonatal resuscitation team should A. Perform routine suctioning and immediately start positive pressure ventilation (PPV). B. Perform endotracheal suctioning if the infant is not crying or breathing effectively. C. Wait for the infant to start breathing on their own before intervening. D. Perform suctioning only if the rate is below 100 EM. Answer. B. Perform endotracheal suctioning if the infant is not crying or breathing effectively. Explanation. In the case of thick meconium-stained amniotic fluid, it is essential to perform endotracheal suctioning if the infant is not crying or breathing effectively. This is because meconium aspiration can obstruct the airways and lead to respiratory distress. Suctioning the trachea with an endotracheal tube allows for the removal of meconium and improves ventilation. Routine suctioning is insufficient for thick meconium, and waiting for spontaneous breathing could delay necessary intervention. The NRP guidelines stress that effective management of meconium aspiration requires proactive airway clearance, especially when there are signs of respiratory distress. The heart rate is not a deciding factor for initiating suction in these cases. Question 4. A neonate is born via emergency cesarean section at 30 weeks gestation. The infant is apneic, has weak respiratory effort, and a heart rate of 90 bpm. The resuscitation team initiates positive pressure ventilation (PPV). After 30 seconds, the infant's heart rate improves to 110 bpm, but the infant remains slightly cyanotic and oxygen saturation levels are still below 80%. What is the most appropriate next step in this situation? A. Increase the oxygen concentration to 100% and continue PPV. B. Stop PPV, reposition the infant and attempt to stimulate the infant. C. Start chest compressions and administer epinephrine via. D. Assess for airway obstruction and consider intubation if the ventilation is not effective. Answer D. Assess for airway obstruction and consider intubation if the ventilation is not effective. Explanation. For a premature neonate, 30 weeks gestation, who remains cyanotic and has low oxygen saturation despite a heart rate above 100 bpm, the next step is to assess for airway obstruction and ensure that ventilation is being delivered effectively. The NRP guidelines recommend checking the position of the head and the airway is open, and if there is no improvement, intubation should be considered. Increased oxygen concentration to 100% is appropriate if the infant remains hypoxic, but it should be done alongside effective ventilation, which is the priority. Chest compressions are not indicated unless the heart rate is below 60 bpm despite effective PP. Question 5. During a neonatal resuscitation, you are providing bag mask ventilation (BVM) to a term infant. The infant is not responding to the ventilation and there is no improvement in the chest rise. What should you do next according to the NRP guidelines? A. Reassess the mask fit and ensure a proper seal while continuing ventilation. B. Start chest compressions to increase oxygenation. C. Increase the oxygen concentration to 100% and continue the BVM. D. Administer epinephrine immediately via an umbilical venous catheter. Answer A. Reassess the mask fit and ensure a proper seal while continuing ventilation. Explanation. The most appropriate first step when there is no improvement with bag mask ventilation (BVM) and no chest rise is to reassess the mask fit and ensure a proper seal. A poor seal is a common cause of ineffective ventilation. Ensuring that the mask is positioned correctly over the infant's nose and mouth and checking for tight fit can resolve this issue. Continuing ventilation with proper technique is crucial for effective oxygenation. Chest compressions or epinephrine should not be administered unless the heart rate drops below 60 bpm despite effective ventilation. Question 6. A neonate is delivered with a weak cry and is not breathing effectively. The initial assessment shows a heart rate of 110 bpm and a GAR score of 4 at 1 minute. The team provides PPV with a mask in a self-expanding bag. After 30 seconds of ventilation, the infant's heart rate improves to 130 bpm, but the infant remains cyanotic. What should be the next step? A. Administer oxygen via nasal cannula to help with oxygenation. B. Intubate the infant and increase the positive pressure during ventilation. C. Continue PPV and reassess every 30 seconds for further improvement. D. Start chest compressions immediately as the heart rate is still below 100 EM. Answer. B. Intubate the infant and increase the positive pressure during ventilation. Explanation. Since the infant's heart rate has improved to 130 bpm, the next step would be to improve oxygenation, and intubation should be considered if PPV with mask is ineffective. The NRP guidelines recommend increasing the positive pressure during ventilation or considering intubation in cases where there is inadequate ventilation with BAM. Intubation provides more secure airway and allows for better control of ventilation. Continuing with PPV without addressing potential airway issues is less effective. Chest compressions are not indicated unless the heart rate drops below 60 bpm despite adequate ventilation. Question 7. Mr. Johnson, a neonatal nurse, is resuscitating a preterm infant born at 26 weeks gestation. The infant is showing signs of respiratory distress and there is concern about possible hypoxia. The team decides to use continuous positive airway pressure (CPAP). What should Mr. Johnson ensure before starting CPAP for the infant? A. Ensure that the infant's airway is clear and that there is no need for suctioning. B. Use high-flow nasal cannula instead of CPAP for better oxygenation. C. Ensure the infant's heart rate is stable above 100 bpm before starting CPAP. D. Start the CPAP immediately as it is the first intervention needed in preterm infants with respiratory distress. Answer. A. Ensure that the infant's airway is clear and that there is no need for suctioning. Explanation. Before initiating CPAP, Mr. Johnson should first ensure that the infant's airway is clear and that suctioning is not required. CPAP is non-invasive ventilation technique used to help preterm infants with respiratory distress by maintaining positive pressure in the lungs, but it is important that there are no obstructions in the airway that could impair the effectiveness. CPAP, it is not necessary for the heart rate to be stable above 100 bpm or EPAP to be used. CPAP should be started when the infant shows signs of respiratory distress, but the airway should be assessed first to ensure there is no obstruction. Question 8. A neonate born at 32 weeks gestation is presenting with respiratory distress syndrome (RDS). The infant's heart rate is stable at 120 bpm, but the oxygen saturation remains low despite the application of CPAP. What is the most appropriate next step? A. Administer surfactant via endotracheal tube. B. Increase the CPAP pressure and continue monitoring. C. Intubate and begin mechanical ventilation. D. Start chest compressions as the oxygen saturation is low. Answer: C. Intubate and begin mechanical ventilation. Explanation: 4. A preterm infant with respiratory distress syndrome (RDS) who does not respond to CPAP and has persistently low oxygen saturation, intubation and mechanical ventilation is the most appropriate next step. CPAP is often insufficient for infants with RDS when their condition deteriorates. Surfactant therapy may be required, but it should be delivered via intube, as it needs to be placed directly in the lungs to be effective. Chest compressions are not indicated unless the heart rate is below 60 bpm despite effective ventilation. Question 9. A term infant is delivered with an AFGAR score of 2 at 1 minute and 5 at 5 minutes. The infant's heart rate is 110 bpm, but the infant is slightly cyanotic and not crying. The neonatal team is performing bag mask ventilation (BVM), but is concerned that it may not be effective. What is the most important step the team should take next? A. Increase the oxygen concentration to 100% and continue with BVM. B. Ensure that the mask fit is tight, reposition the head and continue ventilation. C. Begin chest compressions immediately since the infant is not crying. D. Administer epinephrine if the heart rate remains stable above 100 E. Answer: B. Ensure that the mask fit is tight, reposition the head and continue ventilation. Explanation: the most important next step is to ensure that the mask fit is tight and reposition the infant's head to optimize the airway. Poor mask fit or improper head position can lead to ineffective bag mask ventilation (BVM). Repositioning the head and adjusting the mask for better seal is essential for improving ventilation, increasing the oxygen concentration. Help, but it should be done alongside improving the effectiveness of ventilation. Chest compressions are not required unless the heart rate drops below 60 bpm, and epinephrine is used only if the heart rate is below 60 bpm despite chest compressions. Question 10. A neonate is born at 34 weeks gestation with signs of mild asphyxia. The resuscitation team decides to start positive pressure ventilation (PPV) and provide oxygen therapy. After 30 seconds of PPV, the infant's heart rate is 120 bpm, but the infant is still cyanotic. What should the team do next according to the NRP guidelines? A. Continue PPV with higher pressures and reassess every 30 seconds. B. Increase the oxygen concentration to 100% and continue PPV. C. Perform endotracheal intubation to improve ventilation effectiveness. D. Start chest compressions if the heart rate is above 100 EM. Answer: A. Continue PPV with higher pressures and reassess every 30 seconds. Explanation: the team should continue PPV with higher pressures and reassess the infant's condition every 30 seconds. If the heart rate remains stable above 100 bpm but the infant is still cyanotic, the next step is to increase the pressure during PPV to ensure adequate ventilation. This approach is consistent with the NRP guidelines, which emphasize optimizing ventilation before moving to more advanced interventions like intubation or chest compressions. Increasing the oxygen concentration may be helpful, but improving ventilation effectiveness through PPV is the priority. Chest compressions are only indicated if the heart rate drops below 60 bpm. Question 11. A neonate is born at 35 weeks gestation via spontaneous vaginal delivery. The infant has a weak cry and is not breathing effectively at birth. The heart rate is 80 bpm and the infant appears pale with minimal movement. The neonatal team begins positive pressure ventilation PPV. After 30 seconds of PPV, the heart rate improves to 100 bpm, but the infant remains slightly cyanotic, with oxygen saturation levels of 85%. What is the next best step? A. Increase the oxygen concentration to 100% and continue PPV. B. Stop PPV, reassess the airway and reposition the infant's head. C. Start chest compressions as the heart rate is still below 120 bpm. D. Administer epinephrine via an umbilical venous catheter. Answer: B. Top PPV, reassess the airway and reposition the infant's head. Explanation: if the heart rate improves to 100 bpm but the infant remains cyanotic, the next step is to reassess the airway and reposition the infant's head to optimize the effectiveness of PPV. Poor seal or improper head position could lead to ineffective ventilation. Even if the heart rate improves, increasing the oxygen concentration may help, but it should be done along with improving the ventilation technique. Chest compressions and epinephrine are not necessary as the heart rate is stable at 100 EM. Question 12. A neonate is born at 28 weeks gestation via emergency cesarean section. The infant is limp with no spontaneous movement, a heart rate of 60 bpm, and is not breathing. The resuscitation team begins positive pressure ventilation (PPV). After 30 seconds, the heart rate improves to 80 bpm, but the infant is still not breathing and remains cyanotic. What is the appropriate next step? A. Reassess the airway, increase PPV pressures, and continue ventilation. B. Start chest compressions and administer epinephrine immediately. C. Increase oxygen concentration to 100% and continue PPV. D. Intubate and provide mechanical ventilation for the neonate. Answer. A. Reassess the airway, increase PPV pressures, and continue ventilation. Explanation. For an infant with a heart rate of 8 bpm who is not breathing effectively, the next step is to reassess the airway and increase the pressure during PPV. The team should focus on ensuring that the airway is clear, the mask is properly positioned, and the ventilation pressures are adequate. Chest compressions are not indicated until the heart rate drops 60 bpm, and epinephrine administration is also delayed until the heart rate is below 60 bpm despite effective ventilation. Question 13. A term infant is born with mild respiratory distress. The infant has a heart rate of 140 bpm and is breathing, but with shallow respirations and some chest retractions. The oxygen saturation is 88%. What is the best initial intervention for this infant? A. Administer surfactant via endotracheal tube. B. Provide supplemental oxygen via nasal cannula. C. Start positive pressure ventilation (PPV) with a self-expanding bag. D. Initiate continuous positive airway pressure (CPAP). Answer. D. Initiate continuous positive airway pressure (CPAP). Explanation. 4. A term infant with mild respiratory distress and shallow breathing, continuous positive airway pressure (CPAP) is the best initial intervention. CPAP helps keep the airways open and can improve oxygenation, especially in infants with signs of mild respiratory distress. If the infant's condition does not improve, more advanced interventions like PPV or surfactant may be needed. Providing supplemental oxygen via nasal cannula is not typically sufficient for neonate in respiratory distress. Question 14. A neonate is born at 32 weeks gestation with a heart rate of 130 bpm and shows signs of mild respiratory distress. The team decides to administer CPAP. After a few minutes, the infant's oxygen saturation increases to 92%, but the infant continues to show signs of mild cyanosis. What should the team do next? A. Administer oxygen via high-flow nasal cannula. B. Increase CPAP pressure and monitor the oxygen saturation. C. Intubate and provide mechanical ventilation. D. Reassess the mask fit for CPAP and continue monitoring. Answer. B. Increase CPAP pressure and monitor the oxygen saturation. Explanation. If the infant's oxygen saturation improves with CPAP but remains suboptimal, 92%, and there is continued cyanosis, increasing the CPAP pressure is the next appropriate step. CPAP is effective in maintaining lung expansion and improving oxygenation. If increasing CPAP pressure does not resolve the cyanosis, intubation and mechanical ventilation may be necessary, but this should only be considered after optimizing CPAP. Question 15. A 26-week preterm infant is born and requires resuscitation. The infant is limp and the heart rate is 50 bpm. The team immediately begins positive pressure ventilation (PPV). After 30 seconds, the heart rate improves to 100 bpm, but the infant is still not breathing and remains cyanotic. What is the appropriate next step? A. Start chest compressions and administer epinephrine. B. Continue PPV with higher pressure and reassess the infant. C. Intubate the infant and initiate mechanical ventilation. D. Administer surfactant via endotracheal tube. Answer. B. Continue PPV with higher pressure and reassess the infant. Explanation. If the heart rate has improved to 100 bpm, the priority is to continue positive pressure ventilation with higher pressures to ensure that the infant is adequately oxygenated. Reassessing the technique and ensuring the mask is properly sealed and positioned is crucial for improving ventilation. Chest compressions and epinephrine are only indicated if the heart remains below 60 bpm despite effective ventilation. Question 16. A 32-week preterm neonate is delivered via cesarean section. The infant has a heart rate of 120 bpm but is struggling with respiratory distress. The team begins positive pressure ventilation (PPE) for 30 seconds. The heart rate improves to 130 bpm, but the infant remains cyanotic. What is the next step? A. Continue PPV and reassess every 30 seconds. B. Administer surfactant immediately via endotracheal tube. C. Start chest compressions and provide epinephrine. D. Increase the oxygen concentration to 100% and continue PP. And so, A. Continue PPV and reassess every 30 seconds. Explanation. In this case, the infant has responded to PPV with an improved heart rate but still shows signs of cyanosis. The next step is to continue PPV and reassess every 30 seconds. Increasing the oxygen concentration to 100% is also appropriate, but improving ventilation is the priority. Chest compressions and epinephrine are not indicated unless heart rate falls below 60 bpm despite effective ventilation. Question 17. A neonate is born at 30 weeks gestation via emergency cesarean section. The infant is limp and the heart rate is 55 bpm. The neonatal team begins positive pressure ventilation PPV. After 30 seconds, the heart rate increases to 90 bpm, but the infant remains unresponsive. What is the most appropriate next step? A. Increase PPV pressure and continue monitoring. B. Start chest compressions as the heart rate is still below 100 bpm. C. Administer epinephrine via the umbilical venous catheter. D. Intubate and provide mechanical ventilation. Answer. B. Start chest compressions as the heart rate is still below 100 bpm. Explanation. Since the heart rate is still below 100 bpm despite PPV, the next step is to begin chest compressions. Chest compressions are indicated if the heart rate remains below 60 bpm after 30 seconds of effective ventilation. Intubation or epinephrine should only be administered if the heart rate remains below bpm after chest compressions. Question 18. A neonate is born at 38 weeks gestation with a low heart rate of 50 bpm and no respiratory effort. The team begins positive pressure ventilation PPV. After 30 seconds, the heart rate improves to 7 bpm, but the infant is still not breathing effectively. What should be the next intervention? A. Continue PPV with higher pressure. B. Begin chest compressions and administer epinephrine. C. Administer surfactant via endotracheal tube. D. Intubate the infant immediately. Answer. A. Continue PPV with higher pressure. Explanation. When the heart rate is below 80 bpm but not below 60 bpm, the best next step is to continue PPV with higher pressure. The team should assess the effectiveness of the ventilation and ensure the airway is open. Chest compressions are not necessary unless the heart rate drops below 60 bpm despite effective ventilation. Intubation and surfactant administration may be necessary if the PPV is ineffective. Question 19. A neonate is born at 30 weeks gestation. The infant is limp with no respiratory effort, a heart rate of 50 bpm, and no signs of life. The team immediately begins positive pressure ventilation PPV. After 30 seconds, the heart rate increases to 80 bpm, and there is slight improvement in respiratory effort. What should the team do next? A. Start chest compressions as the heart rate is still below 100 bpm. B. Administer epinephrine and continue PPV. C. Reassess the airway and increase the PPV pressure. D. Intubate the infant immediately. Answer. C. Reassess the airway and increase the PPV pressure. Explanation. If the heart rate improves to 80 bpm but there is still inadequate respiratory effort, the team should reassess the airway and increase the pressure during PPV. Ensuring that the airway is open and ventilation is effective is critical in this situation. Chest compressions are not indicated until the heart rate drops below 60 bpm, and epinephrine should only be administered if the heart rate remains below 60 bpm despite resuscitative efforts. Question 20. A neonate is born at 32 weeks gestation and has weak respiratory effort. The team is concerned about possible surfactant deficiency and begins positive pressure ventilation PPV. After a few minutes, the infant's heart rate stabilizes at 120 bpm, but there is still some oxygen desaturation. What should the team do next? A. Intubate and administer surfactant via endotracheal tube. B. Increase the oxygen concentration to 100%. C. Start chest compressions immediately as the oxygen saturation is low. D. Continue PPV with reassessment every 30 seconds. Answer A. Intubate and administer surfactant via endotracheal tube. Explanation. In this case, if the infant is still experiencing oxygen desaturation despite stable heart rate and effective PPV, the next step would be to intubate and administer surfactant. Surfactant deficiency is common in preterm neonates, and your PPV does not resolve the desaturation. Surfactant administration can help improve lung compliance. Question 21. A preterm neonate is born at 32 weeks gestation via cesarean section due to fetal distress. Upon delivery, the infant is floppy and has no spontaneous movement. The heart rate is 45 BPM and the infant is not breathing. What is the first intervention to initiate? A. Begin positive pressure ventilation (PPV). B. Start chest compressions. C. Administer epinephrine via endotracheal tube. D. Administer surfactant immediately via endotracheal tube. Answer A. Begin positive pressure ventilation (PPV). Explanation. 4. A neonate with no spontaneous movement, a heart rate below 60 BPM, and no breathing effort. The first intervention is positive pressure ventilation (EPP). Would be initiated immediately to improve oxygenation and support the infant's heart rate. Chest compressions, epinephrine, and surfactant are not indicated until after effective ventilation established or the infant's condition does not improve. Question 22. A neonate is born at 29 weeks gestation and is not breathing effectively. The team initiates positive pressure ventilation (PPV), but after 30 seconds the heart rate is still 50 BPM and there is no improvement in the respiratory effort. What is the appropriate next step? A. Reassess the airway, increase EPV pressures, and continue ventilation. B. Start chest compressions immediately. C. Intubate and administer surfactant. D. Administer epinephrine via umbilical venous catheter. Answer B. Start chest compressions immediately. Explanation. If the heart rate is below 60 BPM after 30 seconds of PPV and the infant is not improving, the next step is to start chest compressions. Chest compressions should be initiated if the heart rate remains below 60 BPM despite effective ventilation. Intubation and surfactant are not the first interventions if the heart rate is still low after PP. Question 23. A neonate is born at 34 weeks gestation with a heart rate of 125 BPM, shallow respirations, and mild cyanosis. The oxygen saturation is 88%. What is the best initial intervention? A. Begin positive pressure ventilation (PPV) with a self-expanding bag. B. Administer CPAP to improve oxygenation. C. Intubate and provide mechanical ventilation. D. Increase the oxygen concentration to 100% and continue monitoring. Answer B. Administer CPAP to improve oxygenation. Explanation. 4. A neonate with shallow respirations and mild cyanosis, continuous positive airway pressure, CPAP is the best initial intervention. CPAP can improve oxygenation by keeping the airways open and preventing atelectasis. If the infant's condition does not improve, further interventions such as PPV or intubation may be necessary. Question 24. A neonate is born at 37 weeks gestation. The infant has a weak cry, low muscle tone, and a heart rate of 80 BPM. The infant is breathing, but not effectively. After 30 seconds of positive pressure ventilation (PPV), the heart rate improves to 110 BPM, but the infant remains slightly cyanotic. What is the next best step? A. Increase the oxygen concentration to 100% and continue PPV. B. Reassess the airway, reposition the head, and continue ventilation. C. Start chest compressions as the heart rate is still below 120 BPM. D. Administer epinephrine via the umbilical venous catheter. Answer B. Reassess the airway, reposition the head, and continue ventilation. Explanation. If the heart rate improves to 110 BPM but the infant remains cyanotic, the next step is to reassess the airway and reposition the infant's head to ensure that ventilation is effective. It is essential to optimize the technique of positive pressure ventilation before considering more advanced interventions like chest compressions or epinephrine. Question 25. A neonate is born at 36 weeks gestation. The infant is limp with no respiratory effort and has a heart rate of 50 BPM. The team begins positive pressure ventilation (PPV). After 30 seconds, the heart rate improves to 80 BPM, but the infant is still not breathing effectively. What is the most appropriate next step? A. Begin chest compressions as the heart rate is still below 100 BPM. B. Reassess the airway, increase PPV pressures, and continue ventilation. C. Administer epinephrine via the umbilical venous catheter. D. Intubate and administer surfactant. Answer: B. Reassess the airway, increase PPV pressures, and continue ventilation. Explanation: if the heart rate is below 100 bpm after 30 seconds of PPV, the next step is to reassess the airway and increase the ventilation pressures. Ensuring that the airway is open and the ventilation technique is effective is essential before proceeding with more invasive interventions like chest compressions or epinephrine. Question 26. A neonate is born at 28 weeks gestation and has weak respiratory effort and a heart rate of 95 bpm. The infant is receiving positive pressure ventilation (PPV). After a few minutes, the heart rate improves to 120 bpm, but the infant remains slightly cyanotic. What should be the next step? A. Continue PPV and reassess every 30 seconds. B. Administer oxygen via a high-flow nasal cannula. C. Start chest compressions immediately. D. Increase the oxygen concentration to 100% and continue PP. Answer: A. Continue PPV and reassess every 30 seconds. Explanation: if the heart rate improves to 120 bpm but the infant remains cyanotic, the next step is to continue PPV and reassess every 30 seconds. Improving ventilation is the priority in this scenario. Oxygen concentration may be increased to 100%, but continued support at PPV is essential for addressing the cyanosis. Question 27. A neonate is born at 32 weeks gestation and is not breathing effectively. The team begins positive pressure ventilation (PPV). After 30 seconds, the heart rate improves to 100 bpm, but the infant remains cyanotic and has oxygen saturation of 90%. What is the appropriate next step? A. Continue PPV with reassessment every 30 seconds. B. Start chest compressions. C. Increase the oxygen concentration to 100% and continue PPV. D. Intubate and administer surfactant. Answer: C. Increase the oxygen concentration to 100% and continue PPV. Explanation: if the heart rate improves to 100 bpm but the infant remains cyanotic, the next step is to increase the oxygen concentration to 100% and continue PPV. Effective ventilation should be the focus, and increasing the oxygen concentration may help improve oxygenation. Intubation and surfactant may necessary if PPV is ineffective. Question 20. A neonate is born at 30 weeks gestation with a heart rate of 45 bpm and no spontaneous breathing. The team begins positive pressure ventilation (PPV). After 30 seconds, the heart rate improves to 75 bpm, but there is still no improvement in the respiratory effort. What is the next step? A. Start chest compressions as the heart rate is still below 100 bpm. B. Reassess the airway and increase EPV pressures. C. Intubate and administer surfactant. D. Administer epinephrine via umbilical venous catheter. Answer: B. Reassess the airway and increase PPV pressures. Explanation: if the heart rate improves to 75 bpm after 30 seconds of PPV, but there is still no improvement in respiratory effort, the appropriate next step is to reassess the airway and increase EPV pressures. Effective ventilation is essential to improve oxygenation and support the heart rate. Chest compressions and epinephrine are not necessary unless the heart falls below 60 bpm despite effective ventilation. Question 29. A neonate is born at 34 weeks gestation with weak respiratory effort and a heart rate of 130 bpm. The team begins positive pressure ventilation (PPV). After 30 seconds, the heart rate improves to 150 bpm, but the infant remains slightly cyanotic. What is the best next step? A. Continue PPV and reassess every 30 seconds. B. Intubate and provide mechanical ventilation. C. Start chest compressions immediately. D. Increase the oxygen concentration to 100% and continue PP. Answer: D. Increase the oxygen concentration to 100% and continue PPV. Explanation: if the heart rate improves to 150 bpm but the infant remains cyanotic, the next step is to increase the oxygen concentration to 100% and continue PPV. Oxygenation is the priority in this situation. Intubation and mechanical ventilation would be considered only if PPV does not improve the infant's oxygenation. Question 30. A neonate is born at 28 weeks gestation. The infant has no spontaneous breathing and a heart rate of 50 bpm. The team begins positive pressure ventilation (PPV). After 30 seconds, the heart rate improves to 80 bpm, but there is no improvement in the respiratory effort. What is the appropriate next step? A. Start chest compressions as the heart rate is still below 100 bpm. B. Reassess the airway, increase EPV pressures, and continue ventilation. C. Intubate and administer surfactant. D. Administer epinephrine via the umbilical venous catheter. Answer. B. Reassess the airway, increase PPV pressures, and continue ventilation. Explanation. If the heart rate improves to 80 bpm but the infant is still not breathing effectively, the next step is to reassess the airway and increase the PPV pressures. Ensuring that the ventilation technique is effective is critical. Chest compressions and epinephrine are not indicated unless the heart rate remains below 60 bpm despite effect. Ventilation.